attending our symposium. I'm so excited to be here today and have the opportunity to present our guest speaker, Professor Dennis McGonagle, who is coming to us from the United Kingdom. He's a professor of investigative rheumatology and head of the experimental rheumatology at the University of Leeds. Professor McGonagle is internationally recognized for his work in microanatomy and imaging to elucidate the pathogenesis of inflammatory disease, and especially the basis for immune activation at a human enthesis in seronegative arthritis. He's also known for his work in the biology of mesenchymal stem cells in arthritis and their role in pathogenesis repair in rheumatic diseases. He has published over 280 articles on these topics. His talk today is entitled Making the Invisible Visible, the Impact of Secukinumab in Ankylosing Spondylitis Management. We're grateful for his presence among us today, and so without any further delay, Professor McGonagle, please go ahead and get started. Thank you.
Okay, thank you very much, Fatima. I know lunch is coming up, yeah, and you've been moving the last speakers ahead pretty fast. I've been to Jordan before, and it's wonderful to be back. This talk is sponsored by Novartis, and I enjoy funding from Novartis in my lab. So I work in the UK, but I come from this part of Ireland here, northwest, just up here. I can't get it. I'll be here all day. Just there. Yeah. I live right in the north of Ireland, and I saw a picture of winter in Jordan, which looks like summer in Ireland. It's very wet and windy. And the new Star Wars film was shot near my mother's house in Ireland, and the BBC described my part of Ireland, Donegal, as the coolest destination. So everybody believes everything that the BBC says. So I'm going to be talking about ankylosing spondylitis in particular, and spondyloarthropathy. And the whole spondyloarthropathy story started in Leeds, where I happened to work, by Werner Wright when he recognized PSA. And then with Moll in Leeds again, he recognized that ankylosing spondylitis was strongly linked to the other spondyloarthropathy manifestations, and I'll be touching on gut disease and eye disease later in my talk. And this was the spondyloarthropathy concept, ankylosing spondylitis and other diseases that affect the spine that were negative for rheumatoid factor. Now, one of the characteristics of ANK-SPON, but you don't see it in every patient, is peripheral enthesitis. And of course, all of the spinal bone formation in ANK-SPON, which we call syndesmophytosis, is a type of enthesopathy. The question was whether this new bone was linked to bone inflammation or not, and that has only become clear in this past few years. And the importance of enthesitis and ankylosing spondylitis was underpinned by this development in 1987. It's called the Mandor Index, where they counted 66 tender insertions, many of them along the spine. I'm not really getting the hang of this, but yeah, along the spine. And I've been very interested in the underlying pathogenic mechanisms. So when I was a fellow, I wondered if there might be a lot more enthesitis than we recognized in spondyloarthropathy. And to cut a long story short, we did lots of imaging studies showing enthesitis in inflamed joints, not just in the spine, but in the peripheral skeleton. And we proposed this cytokine-mediated model where abnormalities at the enthesis, including in TNF and IL-1, IL-17 had only just been described back then, but it wasn't really understood. But we proposed that cytokines drove these diseases from the enthesis, and this is the unified pathological concept. Now, when you talk about an enthesis, it's much more than just a focal attachment. So here's the focal attachment, and this is the enthesis in the old days as we understood it, with tendon or ligament, fibrocartilage, then calcified fibrocartilage and underlying bone. But we discovered that the enthesis actually is what we term an enthesis organ, and as well as these attachment sites proper, there is cartilages lining the adjacent bone, and I could be here all day with this. Yeah, here. There's cartilages lining the adjacent bone, and this forms a synovioenthesial complex. And the peripheral entheses in particular have this adjacent synovium, which is part of the enthesis organ. And I'll say more about that. Now, one of the things when you hear nice lectures on rheumatoid arthritis, it's a very easy disease to diagnose. 80% are ACPA positive, and it's fairly easy to treat because all of the manifestations tend to respond well to treatment. But in ankylosing spondylitis and the related conditions, there's a lot of immunological heterogeneity. And I'll show you some examples of that, and I'll be talking about that later in my talk. And here's an example of immunological heterogeneity. So this is a paper we just published where patients with bad IBD who failed anti-TNFs, when treated with an integrin blocker, vedolizumab, their bowel disease went into remission, but then they developed a very nasty spondyloarthropathy. This is reminiscent of what used to happen with etanercept. It would treat the angst-spond, but it would flare the IBD. This is the opposite scenario. So there's lots of immunological heterogeneity. And these are some examples of the florid inflammation. Here, this diffuse vertebral osteitis that these patients got. So there's a lot of immunological disease heterogeneity. And there's another issue we face is that when we diagnose these diseases, we often use MRI bone edema patterns. And this is actually an athlete with pubic symphysitis, which is mechanically induced. And this is a patient with spondyloarthritis with symphysis pubis osteitis, which is inflammatory. So we have to be very careful in how we call these diseases. Is the early back pain inflammatory or mechanical? These are other examples of the enthesitis pathology in AS. These are patients with sternal wall involvement. So there's florid osteitis here in white. And also this patient has a Sapho-type diffuse osteitis of the sternoclavicular joint. So most of angst-spond affects the spine, and most of the inflammation is in the bone, which is linked to carriage of the B27 gene. Whereas most psoriatic arthritis affects the peripheral skeleton, and it often involves soft tissue. And this is where we have these synovioenthesial complexes, which are generally absent in the spine, apart from the facet joints. So I'm just going to, before I talk about clinical data, I've given you this story about how the entheses and synovioenthesial complexes seem to underlie the pathogenesis of angst-spond and related diseases. So I'm going to talk a bit about how these diseases kick off. So these diseases, all of them, including uveitis, AS, IBD, there is evidence of dysregulated innate immunity in the skin, in the gut, and at the entheses. And there are IL-23 receptor positive innate lymphocytes in these tissues that in health can make cytokines, including IL-17A and TNF, which are obviously the two big targets in AS. Now, one of these innate immune cells that has been shown to be present in the entheses, particularly in mice, is called gamma delta T cells. And these cells not only prime immunity, as shown here, but they're also involved in tissue repair responses. So why would that be important? Well, this is a picture showing that normal entheses have, on ultrasound, have micro damage here and here. So there's lots of micro damage in all of you healthy people and fellows in training. It just gets silently repaired. And we've published papers showing that normal aged entheses have microscopic inflammation, which is probably part of the normal physiology. So there is damage taking place at entheses, and there's these cells that have been described in mice. And what these are these gamma delta cells that are innate type lymphocytes that respond to stress and can repair the tissue. And in mice, most of these cells have the IL-23 receptor, and they make IL-17, okay? Lots of IL-17 production. So I'm going to show you this is the enthesis bone. So all of these green dots are these cells in the mouse. And here they are in the soft tissue side of the mouse enthesis. And this is a little diagram showing inside that red circle that these gamma delta cells in the mouse, they make lots of IL-17. And in fact, most of the IL-17 in these mice is coming from these cells here, the gamma delta cells, and not the more common alpha beta T cells. Now, I seem to have stuck. Where's my assistant? Oh, sorry, it's come back. I got impatient. So last year we published a paper where we described these cells for the first time in the normal human enthesis in arthritis and rheumatism. So there is different types of cells in the mouse and human, and I'll show you how we did this. So we collect spinous processes from patients undergoing surgery for scoliosis, like here, and then we digest the enthesis soft tissue and bone, and then we do studies on this. So this is normal tissue, but we also occasionally get it from AS. So this is immunochemistry showing these gamma delta T cells in the gut as a positive control, but also in the enthesial bone and soft tissues. Okay? So we digest these tissues in humans, and we compare this to peripheral blood, which is in black, and we release these gamma delta T cells. So there's basically two big populations of gamma delta T cells. One's called V delta 1 and another called V delta 2, just here. There are others, but these are the two big ones. So you can get about 5,000 of these cells per gram of your normal human enthesis. So we all have them in health. And what this slide, so we don't have much time, but what this slide shows using transcriptional analysis of these purified cells is that they express genes that indicate that they're not just circulating around the body, but they're actually resident or long-term inhabitants of the enthesis environment. So this type of cell is called a tissue resident cell. So it's not circulating, but it's in the tissue. And we've done transcriptional analysis of these, and we find that they make molecules like TGF-beta, which is involved in tissue repair. There's lots of JAK-STAT pathway activation in yellow. And there's also immunomodulatory molecule production, including IL-10 and TGF-beta. So all of you sitting in this room have transcripts from your normal innate cells at your enthesis that are making things like TGF-beta and IL-10, but no TNF or no IL-17. So that's status quo when we're in health. So just looking at this in more detail, so we're interested in where the IL-17 is coming from in the spine. And we find that these different cell types, the V delta 1 cells in the peripheral blood express the IL-23 receptor, but the cells in our spinal tissue do not, whereas the V delta 2 cells express the IL-23 receptor. So what this means in common language is that there's a cell population at your enthesis in your spine that is dependent on IL-23, and another cell population that's independent. So what we've done here is we've taken again the normal human enthesis, and we digest these cells, we sort them, and then we stimulate them in vitro to create a disease environment. Then we harvest the RNA and we look at transcripts. So this is the delta 1 cells. You get an increase in TNF, and also in the delta 2 cells you get an increase in TNF. Now, while there's no IL-17 transcript in these V delta 1 cells, and these are the cells that lack IL-23, you can readily induce lots of IL-17A, which now implies that it's possible in vivo, but we don't know the mechanism, whereby you can make IL-17 without IL-23. You'll see where this is going in a second. Now, not unexpectedly, the V delta 2 cells which express the IL-23 receptor also make IL-23. So the data I just showed you was transcript data. Now this is the same experiment where we do intracellular flow cytometry, and this is the delta 1 cells looking at TNF, and you can see it here in the light gray, and also the delta 1 cells here making TNF, and making IL-17A. So the IL-17A protein is being made by cells that lack the IL-23 receptor. And the same happens in the V delta 2 cells that do express the IL-23 receptor. So where might the IL-23 and TNF be coming from in vivo? So when we digest these normal human entheses, here they are, we can isolate myeloid or dendritic cells that from the soft tissue and bone with LPS can be, here's the LPS induction, can be induced to make lots of TNF. And the same is true for IL-23. So in your entheses, you have resident myeloid monocyte dendritic type cells, both in the soft tissue and bony side of the enthesis that can make IL-23, but you have cells in your entheses that are part of innate immunity that can make IL-17 that is not dependent on IL-23. So I focused on innate immunity, which is dysregulated in all of these diseases, and then this primes adaptive immunity. So the B27 effect strongly incriminates conventional T cells such as CD4 and CD8 T cells driving disease. Now, in psoriasis, the difference between psoriasis and eczema is the number of CD8 T cells in psoriasis skin compared to eczema, not CD4 cells, but CD8 T cells. And in mouse models, the CD8 T cells in the dermis and epidermis are big producers of IL-17A, and when you knock out the CD8 T cells, the psoriasis in the mouse model disappears. This is a little model in psoriasis, so injury to the skin, dendritic cell priming, these cells are the enthesis, and then CD8 T cells make a lot of the IL-17 that drive skin disease. So of course, mechanisms like secukinumab are much better in skin clearance than the anti-TNFs. So this is all backed up by translational immunology, or basically clinical trials. So we asked the question, are these CD8 T cells also present in the normal human enthesis? So these red dots on the bottom panel, these are CD3 cells, which again, all of us have in our enthesis. We have up to 250,000 per gram of tissue. And this is unlike the skin or gut. This is a sterile tissue deep in the body that's protected. And when we sort these CD4 cells in black and CD8 T cells in white, when they're not stimulated, they don't make IL-17A on the y-axis here. But when we stimulate them with anti-CD3 antibodies, we can get a big increase in IL-17A. So again, surprisingly to me, all of us have resident adaptive immune cells around our enthesis, adjacent to the fibrocartilage, that don't make IL-17, but they can readily be induced to do this in the lab. And this is a very gentle stimulation of this anti-CD3. And in this case, it's knocked down with a PDE4 blocker. So one of the big stories that's emerged is you would think from the story I'm giving you that anti-IL-17 would be a great strategy in skin, in psoriatic arthritis, angst-bond, and in inflammatory bowel disease. But the trials of inflammatory bowel disease, where all of the basic immunology I just showed you is present, as well as the skin and enthesis, as you know, anti-IL-17s don't work for inflammatory bowel disease. And after the failed clinical trial, the immunologists went back and had a look. So just beside the red circle there, that is a villus in transverse section, and the yellow circle is the lumen, and that is tight junctions. Now that's in health, but when the mice were given anti-IL-17, the tight junctions got completely destroyed and the gut became leaky. And it turns out that basically the gamma delta T cells, here they are, this group, make most of the IL-17 that you find in the mouse gut. So their gamma delta cells appear to be protecting the gut in health. Now, in this experiment, they knocked out IL-23, so now there's no 23, and as you can see, the gut is completely intact. So drugs like ustekinumab and the pure IL-23 blockers seem to be effective in the gut because there seems to be a mechanism where IL-23 is made in the gut and possibly in the enthesis that leads to IL-17 that is necessary for gut homeostasis. So why is IL-17A such a good target in ankylosing spondylitis? I've given you some of the human data from our published work and data we just presented at the ACR as a plenary talk. But there's lots of other genetic data pointing towards the importance of IL-23 and 17 and all of the spondyloarthropathies. And this is a nice slide summarizing that in animal models, IL-17 plays a significant role in erosion and joint destruction and possibly also in new bone formation. And secukinumab is a monoclonal antibody that targets IL-17A, the key cytokine in the 6 members of the IL-17 family. So the proof of the pudding comes from what happens in the clinic. So I'm going to use secukinumab to illustrate how IL-17 is so pivotal in ankylosing spondylitis. So this is the ASA's-Euler recommendations in 2016. This is now obsolete. By the time these recommendations are published, there's new phase 3 studies updating data. And at this point, they were advocating using a anti-IL-17 after TNF inhibition. But of course, we have many patients who we might give a TNF to who might be at risk of tuberculosis, demyelination, or lupus, for example, if they're autoantibody positive. So right away, I would be looking for a mechanism not to give those an anti-TNF. So the original therapies, let's not forget that there's lots of TNF protein produced by those cells at the enthesis. And when TNF was targeted with the 5 available anti-TNFs, it's very effective. So this is up-to-date rheumatology guidelines from this year and last year, and this comes from the Spanish Society, which basically puts IL-17A blockade and ankylosing spondylitis on an equal footing. So I'm going to talk about the link between inflammation and new bone, and I'm using this pivotal Measure 1 study from Novartis. The licensed dose is the 150 milligrams. And in this, the 75 milligrams is not a licensed dose. Now, in this study, as you can see, the patients had 10 milligrams per kilogram loading doses, which is not the current licensed dose, which is 4 weekly injections of 150 milligram loading doses and then monthly injections. So this is slightly different from clinical practice. So this shows the regimen. So the loading doses and then monthly treatment. So patients had a BASD of greater than 4, and some of the patients in this study had failed previous anti-TNFs. Now, as you know, in general, failure of an anti-TNF in rheumatoid or psoriatic is a bad predictor. You tend not to do as well on a new mechanism if you failed one biologic. And in this study, the ASAS outcomes are measured, and the MSAS score was used to calculate new bone formation in the neck and lumbar spine. And this was a study that went on for 4 years, so it was as observed data, and it also had safety data. Patients had, most of them had a CRP of over 5, most of them are B27 positive, and most were anti-TNF naive, about 80%. And so what you can see here, which is very interesting, the lower dose of secukinumab, which is not licensed, on the top line, the purple color, has more radiographic progression. But in the licensed dose, 80% of patients had no radiographic progression. Now, interestingly, in PSA studies of anti-TNFs and secukinumab, you often see erosion healing down at this end, which might point to regression of disease. So this probability plot doesn't show this pattern in AS. And this slide is to show that 80% of people treated with secukinumab over 4 years had no radiographic progression. This is a breakdown of the data from baseline to week 104, where there is very little progression. This is the middle 2 years where the patients are on the standard dose, the 150, where the loading dose is now well out of the system. And as you can see, there's very little radiographic progression in this time. And over 4 years, the rate, there's basically been 1 Stoke unit of progression. So you need 3 units to have 1 syndesma fight. So this is minuscule progression. This is something that's been seen with anti-TNF treatment as well, and that is patients with a high CRP tend to get more progression than patients with a normal CRP. Also, this has been seen before. Males have more progression than females, and this is one of the reasons that women get a bad deal. They have a lot of pain, but the disease takes longer to recognize. But this has been reported with the anti-TNFs. So the best predictor for radiographic progression is baseline syndesmophytosis. So here we see where there is baseline syndesmophytosis, then there is some progression, but it's only 2 units in 4 years versus virtually no progression in this group. So smoking did not have a big difference in this study. As you know, there are some studies showing that smoking is associated with more progression. So just to say a few comments about that. So the disease duration in these subjects in the secukinumab trials is roughly similar to the TNF trials that were done 10, 15 years earlier. But one gets the impression that the earlier patients we treated when we only had anti-TNFs were probably the worst and most progressive and most severe. So a head-to-head study is needed because the impression is that there's less radiographic progression with secukinumab than historical controls. And indeed, that study's been done, as I'll mention. So this is showing good ASAS 40 responses, ASAS 20 responses up to 4 years. This is looking at the small number of patients who had previously been exposed to a TNF, and these patients did very well. So you can see the numbers are small, but most of these patients stayed on the drug for the 4 years. So again, in the real world, when we use secukinumab, and I'm happy to take questions, if you've got somebody with chronic AS who's failed 3 anti-TNFs and their CRP is normal and their MRI doesn't show much osteitis, don't expect miracles. That's my advice, okay? And this is ASAS 40 responses, which are present in over 50% of cases, so this is a higher threshold, which is good. And this is the BASD score, the original scoring system, which the ASAS scoring system is basically very close to that with the inclusion of CRP. And there's a fall of 3 units on the BASD system, which is very good. This is looking at inactive disease, so 1/3 of patients get to an active disease state and stay there. And so one of the very good things about the anti-IL-17s is a very good safety profile. There are humans that lack IL-17A, IL-17F, and other downstream signaling components, and they're prone to superficial fungal infections and respiratory infections, but they don't get tuberculosis. So they have no IL-17, not reduced levels with therapy. So there's no tuberculosis, which is very important in many parts of the world with this agent. No severe toxicity. So obviously the biggest concern you will have is you will all know that 50% of ankylosing spondylitis subjects have low-grade subclinical ileocolitis. And this has been shown in several studies. And you will know that the failed studies of IL-17s in inflammatory bowel disease. So the concern is that you're sitting on an epidemic of IBD. Now in this long-term follow-up, only 5 new Crohn's cases developed, and only 2 new colitis cases developed. So there isn't an epidemic of IBD evolving in these patients. Many of them have subclinical IBD. I don't know if people have done ileocolonoscopic studies in Middle Eastern populations, but it could well be different from Europe. We don't know, and that might be an interesting thing to do. Although I find it difficult how patients would have a colonoscopy if they didn't have symptoms, having done gastroenterology for 6 months. So to summarize, the secukinumab data validates the pivotal importance of the IL-17 pathway in the spondyloarthropathies. It's very compelling. It's a new mechanism that follows on from the anti-TNFs. It's safe and well tolerated. And I'd like to point out now the second IL-17 agent, ixekizumab, has just published data in ankylosing spondylitis showing similar things. So that's that. So just to say now, this is 5-year data, and look at the light blue line. You can see that the secukinumab response keeps on going, and this is showing partial remission at 5 years. So people who start out and do well continue to do well. And I'd just like to point out that the dermatologists are further ahead than us. In dermatology real-world registry data, the retention of secukinumab is about 80% at 1 year. So we wait to see in rheumatology, in registry data, if the retention rate is similar to this trial. And this is the 5-year data. There's lots of numbers there, but the bottom line is there's no more colitis or Crohn's disease developing between year 4 and year 5. And just to emphasize this as well, the dose that's licensed at the moment of secukinumab for AS is 150 milligrams. The dose in skin is 300 milligrams, and the dose in PSA for biologic naive is 150, and 300 in PSA who have failed anti-TNF. So it's remarkable that despite this relatively low dose, that there's this rapid response, very rapid response to secukinumab, which is seen with the standard subcut loading regimen as well. And this is just to emphasize the license strategy. It's 150 milligram loading doses up until week 4, and then monthly. So I have some patients that are partially responding, and in the UK at the moment, we don't have a license for the 300 milligram dose, so this is difficult to try and escalate the dose in the current time. But just to say, so Novartis are doing some studies. They're doing a study looking at radiographic progression compared to a biosimilar anti-TNF. That's a brave study to do. I think it'll be difficult to show differences. All of these agents work well, particularly when used too early. So they select patients with a raised CRP and syndesmophyte. So this is an ongoing study. And so confident are Novartis that secukinumab is the primary cytokine, maybe even primary over anti-TNF. They're doing a study against adalimumab called EXCEED, where they're looking basically at a head-to-head with the ACR20 as a primary outcome. I'd just like to point out that there is a study called SPIRIT-1, where ixekizumab, the other IL-17 blocker, is an active comparator for adalimumab, and there was only one difference, or 2 percentage points, in favor of an ACR20 for ixekizumab over adalimumab. So this is a brave study to do. So to summarize, I've tried to link ANG-SPOND into the whole pathogenetic concept. I've told you about how the IL-23 and 17 axis cytokines and cells that respond to these are present in the normal enthesis. I've also shown you how when these cells are stimulated from healthy people without AS, and also some AS samples, we can induce the proteins TNF and IL-17 from these cells. I've shown that gamma delta T cells, a type of innate cell, are big players in this. And I didn't want to repeat myself, but my talk this afternoon mentions that pure IL-23 blockers failed in ankylosing spondylitis. So there is something about IL-17 production in the spine that is independent of IL-23 that might be driving ankylosing spondylitis. And I've shown you a cell population in the spine that doesn't have the IL-23 receptor, yet can make IL-17 in the lab, but we have no idea what happens in vivo. And the human trials are dissecting this. There's lots of heterogeneity. I didn't mention uveitis, and we know from etanercept days that it doesn't work in the gut, and it's linked to uveitis flares more than the monoclonals. There is a consensus that if patients with AS have active uveitis, that secukinumab would not be the first choice. But again, this needs more registry data. And as I say, this is a very exciting time for the diagnosis and therapy of ankylosing spondylitis. I remember when I started, 33 years ago in rheumatology, the patients with Angst-Spond rarely came to clinic because they said, you can do nothing for us, why should I waste my time? And it's now completely changed, that we're in danger of over-treating people with non-specific MRI lesions. So lots of people I work with in Leeds and in the lab, in my lab group, that have produced all of this data. Thank you very much for listening, and I'm happy to take questions.
Thank you, Professor McGonagle, for the great talk. I think we have a chance for questions. Actually, I have a question for you. For the enthesitis, where you have this immune response on those gamma delta T cells, do we know for how long it can go on before actually it becomes clinically apparent? Does it happen years before the onset of the clinical disease?
Very good question. It's very unclear. Ankylosing spondylitis tends to come on in, males in their late teenage years, and their spines generally look very normal. The normal age spine does get more micro damage in the thoracic vertebrae and lumbar vertebrae. That happens from 30 onwards. So damage in the spine related to non-normal aging seems to mirror the time that spinal fusion starts to occur, but is very unclear as to the preclinical phase in Angst-Spond. However, in psoriasis, it might be different. Up to 50% of psoriasis subjects without arthritis have subclinical ultrasound enthesopathy, and we don't know how long it takes that to progress to clinical disease, if indeed it does progress to clinical disease. We have a paper coming out in Arthritis and Rheumatism online in the next few weeks, where we showed that treatment of the subclinical enthesopathy in psoriasis with ustekinumab leads to regression of the subclinical enthesopathy. So the dermatologist might be accidentally preventing PSA. And if a drug has a license for psoriasis and it independently has a license for PSA, as the IL-17 blockers do, then when dermatologists use them, they might actually be preventing PSA evolution. But this needs to be looked at in registry data.
Question?
Yes. Thank you for interesting lecture. I have a question. In case of partial response in ankylosing spondylitis, would you go for increasing the dose or for combination therapy with other disease-modifying agents like salazopyrene or something else?
Again, very good question. When patients have a partial response and their BASD hasn't fallen, we use BASD in the UK, the first thing I ask is there objective evidence of ongoing inflammation? Because these outcomes are patient-reported outcomes, essentially. So I would look if the CRP's fallen. I would look to see if we did an MRI at baseline, and I would maybe repeat it to see if the osteitis had regressed And if all of the inflammation was gone, I would tell the patient that without the bone edema and fatty corners, it's unlikely you're going to progress. And I might try adjust the NSAIDs or switch to another NSAID or higher dose. I might give a depomedrone steroid injection. But I had one case, like you mentioned, and I persuaded Novartis to provide compassionate use of 300 milligrams for AS. And it took 6 months filling out forms, and by the time it came, the patient had settled. The issue of sulfasalazine, as you know, although ASIS and experts recommend not using sulfasalazine, there are studies from the 90s, the veteran study from Clegg, that showed that sulfasalazine reduces pain in AS. And there's also another study from Europe showing that sulfasalazine reduces pain, yet the experts say not to use it. And the other thing we have to point out is that 50% of these cases have subclinical gut inflammation, which may be in the colon, on the cecal side. Sulfasalazine is known to work in that part of the body for IBD. There's also the link between subclinical gut inflammation and MRI positivity in the spine. So I agree. I think there's a rather compelling case to use a drug like sulfasalazine, particularly since it was synthesized 90 years ago and is perfectly safe during pregnancy, for example. So I think despite the experts saying not to use it, and in fairness, it was used in a study comparing it with etanercept, the German study. I forget the name of the study now, but sulfasalazine made no difference to the MRI lesions in the spine, so there's no good evidence it makes any difference. But I would be tempted to use sulfasalazine, or indeed an alternative DMARD like methotrexate, in a case like this if you can't get what you want.
That's a question.
I have a question. We have the inflammatory enzymes and the non-inflammatory enzymes, I mean the mechanical. Is there maybe a local abnormal cytokine production? Have you crossed such?
Yes, so we're all trained like this. We're trained, is it early morning stiffness and psoriasis and AS, and then it's inflammatory. And then if we have a 50-year-old man who's walking a lot in his job and he has constant pain, it's mechanical. And we tend to say they're two completely different things. But we now know from the mouse models that the inflammatory enthesitis has a mechanical initiation. This is very clear from the mouse models. And there's also a link between the risk of PSA and the body mass index, which points towards mechanics. And the higher your BMI, the more likely you are to get disease. So my point is that rather than trying to say, is it all inflammatory or all mechanical, recognize that there's a mechanical component here, and recognize that during degeneration, there's microscopic or maybe macroscopic inflammation as part of the normal healing. And sometimes steroid injections work for mechanical disease. So what I would say is basically just treat everything you can. So if I have a patient and I'm not sure, I'll get them to lose weight, I'll get physiotherapy, I'll get stretches for their enthesis, I'll get insoles for their shoes, I'll inject steroids, and if everything else beats me, even if it's isolated enthesitis, I will go for a trial of biologic, just as you would use steroids in suspected polymyalgia rheumatica. And if the patient gets better, you go, well, it is PMR. And likewise, I think it may come to using a trial of biologics. So this is a very complex area, and that's my approach. Rather than trying to pull it apart, I treat everything that might be modifiable.
Yeah, I would like to make a comment about what you just said, because it's really difficult and sometimes things not clear. I remember a case scenario where I had a patient with psoriasis, non-specific joint pain, nothing to suggest a psoriatic arthritis by definition, and she was morbidly obese, and she had this heel pain continuous, and we tried, as you said, all the supportive measures, and nothing worked. MRI non-specific, but with 3 months trial of anti-TNF, she was a different person. So we knew it was probably an inflammatory enthesopathy.
Yes, and that's a really great example of that obese type patient. And I not infrequently see psoriasis patients who do have osteoarthritis and plantar fasciitis, and it's very difficult to tell, but I would say that the injury that mechanical factors induce normally leads to healing. And there's an immune system there to do that. All of this TNF and IL-17 that we can make at our enthesis is part of physiology and tissue repair. When people get very old, they get, like, for example, dementia, but they can still walk. You go to a nursing home and they've got the latches high up because the people can escape because their entheses are still working while their brain isn't. So entheses are amazing structures that can repair, even into people more than 100 years old. They're incredibly resilient. And the immune system is there for a purpose, and we have to now think more, is it mechanical predominant or inflammatory or this mixture? And as your case illustrates, this is the only way to find out. The problem is a patient like that you can only treat if they have bad psoriasis. In the UK, we need 3 swollen joints, or we need axial spondyloarthritis in order to give a biologic. But can you give biologics in Jordan for isolated enthesitis?
That actually was in the States. So I made the case about psoriatic arthritis with enthesitis and was approved. Yes.
Okay, they can use whatever they want, whenever they want, yeah.
So you have one more question, Dr. Nadira?
Right. Yeah, great presentation, thank you. I'm intrigued, here.
Oh, sorry, new glasses.
So, actually in the United States, we cannot use whatever we want, whenever we want. It's getting extremely difficult to get medications approved. But intrigued by the data of uveitis and induction of inflammatory bowel disease and the dichotomy of response. Do you think that's, number one, interferon alpha mediated? And second, what's the impact on CD8 cytotoxic cells? And do you think that's toll-like receptor mediated or interaction with possibly CD19 or B cells? So I'm not sure if you're doing flow cytometry data. And I'm mentioning that because I remember that an editorial I wrote years ago about the potential mechanisms of induction of paradoxical reaction of use of anti-TNF in sarcoid, where anti-TNF may induce sarcoid, may induce IBD.
Yes.
And we're seeing that with higher dosages of anti-TNF therapy, and we're seeing that actually when we use that as a monotherapy, whether it's chimeric or human or humanized, we're seeing this phenomenon more and more.
Yes. So I mean that's a great question. That would be a great talk at next year's Congress. There's so many things there. So first of all, the story about interferon is very strong for paradoxical psoriasis and also for TNF-induced lupus. And there's a paper in Nature Communications recently that shows that anti-TNF stops normal dendritic cell maturation, so the plasmacytoid dendritic cell gets trapped in a state of constant interferon, type 1 interferon production in the skin. And this is purely innate immune driven, and it's not CD8 T cell dependent, and this is what apparently drives the paradoxical psoriasis. So there's clearly a link between TNF and autoimmunity. We know this from the induction of lupus in particular, which is also type 1 interferon mediated. So the skin disease seems to be innate immune driven. The lupus is likewise, it drives the interferon, which then drives the autoantibodies. But the other dichotomies like uveitis, it's very poorly understood. Gut disease, very, very poorly understood. There's certainly isolated uveitis responds well sometimes to cyclosporin and azathioprine. So T-cell strategies work. T-cell strategies work in the skin like psoriasis. T-cell strategies work in IBD, particularly colitis. Cyclosporin is very effective for toxic megacolon, but when you stop it, the disease comes back. So CD8 T-cells are important in all 3 sites, but it's not. I've given you the story for the gut disease with IL-17. IL-17 is needed in mice to maintain the gut barrier. So that story was created after the failed trials. It was never predicted. There are some mouse models for anti-IL-17s very effective. That's why these companies spend millions of dollars. But it's unclear what's happening in the eye. This week I saw a patient who had a brilliant response for their skin, and their joints weren't too bad, but they developed for the first time bilateral anterior uveitis. And the clinical trials in Angspond as well with secukinumab reported 21 cases of anterior uveitis, which is probably higher than that level seen with an anti-TNF. So it's not clear what the mechanism is in the eye.
It's getting scary because we're seeing optic nerve involvement, and so it's getting a scary phenomena because we're seeing optic nerve involvement and blindness. So that makes us, as rheumatologists, how often do we need to screen our patients? Because it's and a lot of these are responding to tocilizumab or rituximab, which is kind of interesting.
So are you saying that, so if you have an anti-TNF and you have an anterior uveitis as part of spondyloarthropathy, the overspill of inflammatory mediators into the retina can trigger a cystoid macular edema, right? It's not usually optic nerve, right? And those cases usually respond to an anti-TNF, monoclonal, typically adalimumab. Are you saying you're seeing isolated optic nerve involvement under secukinumab? Because when we see that with an anti-TNF, we would say it's a papillitis or a retrobulbar neuritis, which is part of the MS spectrum, which TNF is known to induce. Can I clarify? Are you saying you're seeing optic nerve involvement with secukinumab?
More with anti-TNF.
Yes, okay. Yeah,
More with anti-TNF,
yeah,
absolutely.
Yeah, so that could be the demyelination unmasking that TNFs do. I mean, the bottom line is secukinumab failed in 3 clinical trials of pan-uveitis. None of these patients had isolated anterior uveitis. So the failed trials were pan-uveitis, which is not part of the disease we're talking about, except in very rare circumstances when the severe anterior inflammation spills into the vitreous and then triggers a cystoid macular edema, as you mentioned. And that type of edema can respond to tocilizumab, which is quite amazing. It's IL-6 dependent. So this is why the whole spondyloarthropathy area is so interesting, and it's actually quite frightening, because you treat people well with a drug and the primary manifestation you've treated is brilliant, and then they turn up with something in another organ which can be quite severe.
I don't think we have any more questions, so thank you everyone for your attendance. You have a pleasant rest of the day. Thank you for the great talk.
Thank you. Good. I got my thing. Thank you. I'll be back. Thanks, Fatima. Is that okay?